Hey, DNA. Kate Wilson here with another episode of All Access DNA. Today we are talking to Nevena Christic, she, her, a prenatal genetic counselor about teratogens. The term teratogen refers to an agent, such as an infection, medication, or environmental exposure that can interfere with the growth or development of the fetus. We talk about specific known teratogens as well as how impacts of teratogens are assessed. Nevena also shares resources for pregnant individuals to learn more about exposures and potential teratogenic effects. Let's get started. Hi, Nevena. I'm so excited to have you on the show today.
I'm so excited to be here. Thank you for having me.
One of your many roles is working as a teratogen information specialist at Mother to Baby. Can you tell us more about what a teratogen is and the work that you do at Mother to Baby?
Yeah, of course. Teratogen really can be any exposure, and exposure can be anything that you're exposed to, either preconception, so before getting pregnant, during pregnancy, or even during breastfeeding, that can um, lead to some sort of a negative outcome in the pregnancy or the child. For example, it can be a medication, an infection, chemical, and any other substance. And an exposure can, and an outcome can be something like a birth defect, or even things like babies growing small or being born too early, or even some of like neurodevelopmental issues that we may see later on. So really, any exposure that can cause a negative outcome will be called a teratogen.
Okay. And then, so what do you do at Mother to Baby in order to, I guess, talk to folks about their
Mhm.
exposures?
Yeah, exactly. And that's really what I do as a teratogen information specialist is basically talk to both pregnant individuals or those trying to get pregnant, their family members, or even healthcare providers, or really anybody out there in the community about, what do we know, what information do we have about various exposures, and what kind of problems they could potentially cause if they're used, or if they're not used during pregnancy, what could underlying health conditions cause. So it's really trying to provide them with up-to-date information on the signs that we do have, but trying to personalize it to their case to help them make the best informed choice during pregnancy or breastfeeding.
And you mentioned that personalization. So I know that timing does play a part in kind of assessing the risk of a teratogen or an exposure. Can you tell us a bit more about how the timing of the pregnancy plays into it?
Yeah, timing plays a huge role. Really, there's different times during pregnancy that different things develop. So when we think about, somebody may take a medication and say, I'm really worried about my pregnancy having a birth defect, let's say a hole in the heart. Well, we know that the heart develops during what we call the organogenesis. The organs develop during the first 12 weeks of pregnancy. So we know that if you have an exposure during that time, it could, if it causes heart defects, potentially cause a heart problem at that time. But if now you go and take that exposure potentially down a medication, or have that exposure down the line in the second or third trimester, by that time the heart has already been formed. So it's not going to go back and cause a birth defect. It may cause some other health problems. So timing really matters from the standpoint of like, when did you get exposed? And if that can cause a problem, are those organs, is that part of the body developing or functioning at that time? So we primarily worry about organ development, so birth defects in the first trimester, versus second and third trimester are usually like functional things, like how are now these organs functioning. So an exposure during that time may cause issues in how the body is working, not necessarily how it's formed. Because of that, even some medications that we know are known, what we call known teratogens, meaning we know that they're really well described to cause a problem, usually have a window during which they cause a problem, meaning they have a window of development during which they may cause an issue. And when somebody calls me and says, hey, I took this medication, but I took it during this time, is it going to cause a problem? I'm going to assess how far along they were in pregnancy, what part of the, organs were developing at that time. Does this exposure cause a problem or not? And then I'm going to also think about a couple of other things like doses and duration and some of these other things. So all of that is really, really important when truly assessing somebody's risk.
And that makes me think of the next question that I wanted to ask was about the dosing. And so are you more concerned about a one-time exposure or exposure over the course of the pregnancy? And then are there things like safe doses, I guess, to have during pregnancy?
Um, all of that is really highly dependent on what we're talking about. So, in general, you can sometimes have a one time exposure if it happens during a critical window, at which time that exposure can cause a problem. But most of the time, we're going to be worried about potentially continuous exposure if we're talking about like, can it affect all parts of development? The dose does play a huge role. There's both the dose and then the tissue absorption, like which part of organs it's going to be affected by it. And the best example for this that I can use is Accutane, which probably a lot of people have heard about. It's one of those medications that taken orally for acne, and a lot of people of reproductive age will take it. And we know that when it's used in the first trimester during a certain period of time can cause certain birth defects. But then there's a different version of that medication that's put on topically, and that does not cause the same concern, mainly because, again, it's a difference about how your body's going to absorb something that's put on your skin, where there's a layer of protection before it enters the bloodstream, process the placenta affects the pregnancy versus something that's orally placed in your body. Also, the dose of it that can enter is going to be lower. So we see that with some of these classic examples as well, where there's really a difference in the magnitude or the amount of risk depending on what the dose is that you take and then the timing of the exposure.
So it sounds like that would be good information for somebody to have if they're talking to somebody, mother to baby or another service, is what it was when they took it and the amount that potentially was taken or exposed to.
Yes. So the timing important, the duration, and then thinking about again the way that you took that medication, or the route of exposure is the way that I approach that. So whether it was topical, whether it was something that was ingested, whether it's something that they just smelled or ate, or like depending on what it is, and then how long they were exposed to it.
Yeah, and I was going to ask, what are some of the things that people have called about? Because you mentioned things like Accutane. I know there are other medications that we've talked about, like in medical training, but there are a lot of people that are concerned about hair dye, face creams, all kinds of stuff, things that they eat, deli meat, stuff like that. So, what are some of the common things people call about?
Those are probably the most common. The most common things that people are worried about are, now we're in cold and flu season, so a lot of that, but like during just in general, vast majority are topical, so cosmetic based things, and then some of the like herbal supplements and supplementations. So with the cosmetic stuff, I get a lot of calls about different skincare products. Always joke around, but I'm like, people spend a lot of money on skincare is what I've learned through this job, by like Googling these different ingredients and different products. And we reality is the vast majority of these ingredients have not been studied in pregnancy. But again, these are situations in which we have this route of exposure where we can be more reassuring to individuals that, again, things are not likely to get it high enough of a level in your bloodstream because you put it on the scalp or in a small area of your body like your face. And we can provide them some reassurance. But sometimes we do get ingredients and some of these things that have really absolutely never been studied, or some really like weird ones. Like I
Hmm.
recently had a call, and one of the ingredients was apple seed stem cells. So,
Okay.
I looked at a lot of resources that I have, but that's such a random ingredient that there's never going to be any research on how that's going to affect pregnancy when put on your skin.
Well, and that makes it hard, I think, for the medical professionals, right, to figure out what to tell a patient, because there's probably a lot of things that there's not that much research or info about. So, how would a medical professional treating a patient know if something's harmful or not during
Yeah.
pregnancy?
Yeah. Yeah. I think there's a lot to that, a couple of things. One is, I think as medical professionals, we always need to think about risks and benefits, and really the the risks and benefits that somebody's willing to tolerate. So like going back to skincare, that is something um that if there's not a lot of information on and somebody's very anxious and worried about it, that's something that they could potentially not do for
Hmm.
an amount of time. Even though if that is something that you want to do, again, there's no data to say that this is necessarily harmful. A lot of this is really, really reassuring. So I think there's also nothing wrong with wanting to look good and feel good and dye your hair and do your nails, right? But when we think about some of the other exposures that are now getting into like medications for treating underlying conditions, we really do need to think about like what are we doing this for and what are the benefits of taking the medication and what would it look like if the medication was stopped? Because what we do know is that both our pregnant patients and our healthcare providers overestimate risks with exposures. They do. And a lot of times they don't go to the resources that have the up to date information. People still utilize FDA categories, which have not been used for over a decade now. And they still say, oh, this is a category C. I should be worried about this. When, if I look, 90% of anything that's FDA approved is a category C. That's not informative. So I think the most important thing is to think about, okay, what are the benefits? What am I treating? And then think about what are potentially the risks of the medication that are known and what would it look like if I take this medication out? And then try to get trusted resources that have up to date information. Whether that is using something like a service like Mother to Baby that does have information specialists who have access to this data that's updated, have access to literature, but also have access to other experts in different areas to get information, or, investing in some of these databases or things that do update information if you don't have time to necessarily go looking into primary literature every single day.
Mhm, mm. Well, and that's what I was gonna say is, like, how do you tell good research from bad? And it sounds like, really, if you have these types of questions, it's best to try to find a service like Mother to Baby or a genetic counselor or OBGYN who has access to additional research and studies to look up the information.
Yeah, because I think that is the biggest challenge. Teratology and exposures in general are extremely difficult to study. We can't do your kind of gold standard study where we have a randomized trial and we say, okay, you take this medication, let's see what happens to your baby, right? Like that's not going to happen. Most of our data is very much based on observational studies, so case controls or database based studies, which are, if anybody out there who's worked with data is really messy and there's a lot of confounding factors and a lot of issues that go into that. So, what ends up happening is we have a lot of correlations that come up when you do research like this. And what happens with correlations, oftentimes the ones that have a positive correlation are going to get sensationalized. They're going to go into media. They're going to get, right. We know very well that we don't publish as many negative studies than we do positive studies or negative outcomes. But also, it's going to be based on data that is very much potentially not sturdy or weak associations. So unless you know what you're looking for, it can be very easy to read a paper and be like, oh yeah, look, I saw this odds ratio, it's a relative risk is 30% by taking this medication. But then when you flip that and you look at actual absolute risks, that may go from a 3% to a 4% chance, right? And that's not what people are not looking necessarily at that. And unfortunately, a lot of healthcare providers don't have time to necessarily, they're doing a lot of good things out there, but don't have time to focus on this. It's important to take all that into context and hopefully go to somebody who is aware of what they're looking at. And they're also looking at that data and looking at like confounding factors and looking at recall bias and looking at study design and looking at study sample and looking at all of these things to be able to say, yeah, this is a good study. Here's what we found. Or here's the study. We saw something. It's kind of weak. Once we've now looked at a different way of compared, looked at confounding factors, now it's actually a weak association and hopefully give some reassurance that way or information.
Right. And you had mentioned about weighing the risks and benefits. One of the things that I wanted to touch on is there are some medications that people don't want to just stop before they've talked to somebody. So I didn't know if you could tell us a little bit about that. Like, why would somebody want to wait to talk to somebody before stopping a medication that they're on?
Yeah. I think that's extremely important is to um, not stop medications just because somebody finds out that they're pregnant, especially if they're using them to treat an underlying health condition. Because we do know that poorly controlled maternal health conditions can add increased risk to pregnancy. And in our reproductive kind of population, we see a lot of autoimmune conditions. We see a lot of psychiatric conditions. We see a lot of things like migraines, and those are things that do tend to affect the population. And what we know is for a lot of these conditions, if you stop your medications and your disease is not optimally controlled, meaning you have a flare or you have a lot of changes in the mood, these can affect pregnancy outcomes. They can increase risk for some of these miscarriage, or they're known to increase risk for things like babies not growing well or being born too early or having longer term issues. I think a lot of times what happens is people think that, okay, this is one thing I can control. I can stop this medication. I'm going to stop putting something in my body that can harm my baby, but forget maybe why they're taking this medication in the first place. Or there's a lot of stigma that goes along with it from, providers or family or even themselves feeling like that's something that they need to control. So what we then see is a lot of medications are discontinued, maternal health gets worse, that can then affect pregnancy, potentially have worse outcomes. So what the goal should always be is to try to optimally control the underlying disease with the lowest number of medications at hopefully the lowest effective dose, meaning the dose that's working. What I tend to see a lot is patients will come in and they'll say, okay, this medication works really well for me, but I cut my dose in half because I just wanted to put less in my body. And now my symptoms have come back. And now we've done really nothing. We put a medication in the body for no reason because it's actually hasn't helped at all. So at that point, you may as well not be on it, right? We'd rather you be on something that works so it can ultimately help balance out the negative risks. And pregnancies are not planned. Ideally, in the world where things are planned and people have access to, all the specialists and all the healthcare and don't have as many other, systematic issues that we have going on, the best time to talk about medications and exposures is before getting pregnant. So people can assess, okay, here's this medication, here's the data we have. Does it work well? Are there alternatives? And if there are alternatives, let's try switching right now so we see does it actually help symptoms? Because pregnancy has symptoms that come along with it. And sometimes it's really hard to know, is it a pregnancy symptoms or is a disease getting worse? And if you now switch medications in the first trimester, or you cut cold turkey or something like that, it's going to be really difficult to know what's actually causing an underlying symptom to happen. And it's going to be then even harder to treat some of those symptoms or manage them.
And I do want to shift a little bit because this has partly become part of the discussion of exposure, what's okay to take in pregnancy and pop culture is with Tylenol, right? So it's been in the news a lot lately. So I want to talk about it. Are there any safe over the counter pain relievers to use during pregnancy?
That's a great question. And I will say that there's nothing in pregnancy that's ever really safe, right? There is, what I teach my students, I always say, even too much oxygen can kill you, right? Like there is, going back to what we talked about, timing, dose, reason for use, all of that plays a huge role. But when we think about data and what is available, and when we think about the quality of the data and the years and the amount of data that we have, Tylenol still is the pain reliever in pregnancy that has the most robust data that does not seem to increase risk over background risk. Now, when I say background risk, I think what's extremely important to know is that anytime you go into a pregnancy, and I know all our, prenatal genetic counselors and genetic counselors know this, but you have a background risk. And we say it's about 3% of having a pregnancy with a birth defect. And then you have background risk for other complications that can happen and then things like neurodevelopmental things. So when we look at these studies, it's very important to compare that to the background risk and seeing does it increase risk over that. And again, we have not seen that when we've looked at Tylenol in very, very good studies. Now, what has come out with, Tylenol is some of this weaker data with potential risk links with autism. And there are so many holes in that data where some of the things that I mentioned earlier they're not well designed studies. They don't account for why we're using Tylenol. Most people are not just using Tylenol for fun. It's not one of those medications that you just use for fun, right? Most people are using it to treat fever, but we know uncontrolled fever can cause same problems or similar problems or other problems. And then when we think about like, bias looking back, I mean, I can barely remember what I took in pregnant yesterday. Ask me 5 years from, 5 years ago what I took in my pregnancy. And you're more likely to have recall bias if you had something negative happen than if you had a good positive outcome, right? So there's just so many issues with the studies. But I think the most important thing is that the media just kind of making it more of a clickbait and some of the political stuff that's been going around with it, not actually delving into the data and looking at it. Now, when you think about pain relief, again, it is important to control fever in pregnancy, but pain as well. Pain can be very, very, very debilitating to a lot of individuals. And then people are more likely to then look for alternatives for pain management that may not be as safe. So we know ibuprofen, or what we call NSAIDs,
Hmm.
so your Motrin, your Aleve, some of these other ones, they can increase risks, especially in the second and third trimester for a certain change in the heart, kind of closing a little hole in the heart that's supposed to be there, or how the kidneys function. And then thinking about some other things like opiates, we know that they do have a higher risk for dependence, and they have a higher risk for withdrawals for the baby. So those are the ones where we actually know that there are negative outcomes. And again, then we weigh risks and benefits, and we think about, okay, if you have a high fever and we have these medications, Tylenol or acetaminophen, ultimately the data is reassuring that that would still be the best one to use to manage. But just like with anything, like I said, lower dose, the shortest duration, that actually helps. I tend to ramble on too. I'm like losing my brain halfway through.
Well, I think it's helpful that you mentioned with Tylenol is some of the things for people to think about, but then also some of the things that go into the studies when you're just trying to decide if any medication or exposure is harmful, and that it's much more complex and nuanced how we sift through all of that data. And I do remember being in prenatal clinic and working with patients, and one of the challenges too is usually people are taking multiple things or exposed to multiple things, right? So sometimes it's hard to tease out what's associated with this or how these medications interact with each other.
For sure. And some of the other things that we don't really think about, which is really, and maybe this also has to do a little bit with social media and kind of this whole going back to root cause of things. But people are also taking a lot of supplements. People are also taking, there is a little bit of a push for this like natural is better. But for example, what we know is most of these supplements are not FDA regulated the same way that medications are. And when people independently look at some of these supplementations, you're going to find all kinds of things that are contaminating them, for example. So some things that could potentially have more detrimental outcomes, like even lead, right? So we tend to also not have people report a lot of that, right? People are not reporting like, oh yeah, let me also tell you about these like 1,000 vitamins that I've bought from this influencer online, right? Because there's just generally this sense of they're natural, so they're safe. Even things like medical marijuana and some of these other things that again people are underreporting. But we know that from alcohol too. Alcohol is a known teratogen, right? We know that there's no safe exposure or amount of alcohol in pregnancy, but it is one of the most underreported exposures. And think about how many outcomes that could potentially confound because it's weaved into our social kind of society of just kind of drinking and mom having her drink and some of these other things. And we also
Mhm.
know that while a lot of people don't drink during pregnancy, most again pregnancies are not planned, or there is misinformation out there about alcohol. So, just some of these things that, again, when you're looking at these studies, all of these other confounding factors have to be taken into account because the reality is that probably, somebody who's taken Tylenol once probably took something else as well. And again, we don't know how they interact. But reality is that probably a lot of those things independently did not cause an outcome. Um, going into our genetics, we know things are multifactorial and we know that it's very rare that it's one thing that causes a negative outcome because even in, again, known teratogens, we can have two people who take the exact same teratogen, exact same dose at the exact same time, and one child's going to have a birth defect, the other one is not. So there's more to the story than just I had this exposure and this happened.
Well, and you talk about this collection of data and how we're getting this information. And also I want to think about how that information then is communicated back out to the general public and to pregnant individuals. So there's these public health recommendations that we make off of this data. And there's sort of these general recommendations, right? Like, so I alluded to it earlier, like raw deli meat. If you're pregnant, don't eat raw deli meat. If you're pregnant, don't eat sushi. So if timing dose plays a role, why are broad statements like these given?
Yeah, it's a very good question. So a lot of it has to do with sort of a general public health prevention situation, right? Because eating deli meat, probably for a vast majority of people, if they eat deli meat during pregnancy, they're not going to have a negative outcome. But a listeria outbreak could happen, right? And if one person does get infected by listeria, it can really have detrimental outcomes in that pregnancy. So the thought is that it's not something that most of us can cut out certain things in pregnancy. And the thought is that if we are kind of our campaign is prevention, like let's do all of this, the likelihood is that if everybody else if the general population is not doing it, you're less likely to have this exposure. So it's more of like the general population as opposed to that one single individual. So with that being said, if that one person eats a deli sandwich and they did not know that they were pregnant, the likelihood that that's actually going to be harmful for their pregnancy is very, very unlikely. It's very, very small, right? So again, goes back to personalization. But if you can have a general population and have kind of this public health and says, okay, let's not do this, then you're more likely to not, if something were to happen, to not have those negative outcomes and not have to worry about it. So it's more of a general population than a single person recommendation. With all of that, the bottom line is really, even if there is something that's like, this is absolutely a no-no in pregnancy, people should always try to get personalized risk assessment because, again, no-nos are very much like, okay, this is in general, but they may not be the case for you. I very recently had a patient who needed to get a CT scan for an underlying, potentially a rupture, right? Which if there was a rupture, a splenic rupture, there was a rupture that could potentially lead to a rupture. So like in that situation, we're talking about risks and benefits, even though the guidelines are don't have a CT in pregnancy, right? But that's not the situation for this patient where they're going to need to have a CT because the benefits outweigh the risk.
Right.
So again, when whoever's out there and they say, okay, I cannot do this in pregnancy, I'm really worried about this, I would always say, why? Is it something that's more public health because it's easier to prevent than treat? Or is it really this is causing a problem and I need to now think about, was I exposed during the time when this would cause an issue?
Okay, that's very helpful. You trained as a genetic counselor, and I want to explore this overlap because there's many genetic counselors that staff teratogenic services or provide teratogenic counseling in their general counseling practice. Why is there this overlap with genetics and teratogens?
Yeah. Um, yeah, so in my multiple hats, I am a prenatal genetic counselor as well. So I think a couple of things. So one thing is that we genetics and teratogens overlap a lot, right? Because most of the time, or historically, teratogens have been a study of birth defects, right? And when you think about birth defects, you're thinking about, okay, well, what causes them? And genetics cause a vast majority, a good portion of birth defects, right? So when things are being figured out, when you're kind of trying to figure out, okay, is this exposure going to is this birth defect caused by this exposure? Genetics is going to play a role because it's going to be unfair to say that, I don't know, a certain exposure caused this group of birth defects, but that child had a chromosomal condition, right? Then it did not cause that because there was a chromosomal condition. So what has happened historically is geneticists and genetic counselors were the ones seeing the patients that had birth defects and trying to kind of tease out what are the causes, what are the exposures, are there anything, or is this a genetic etiology? Do we need to do testing? The other thing is that the geneticists and the pediatricians are the ones that are going to be observing things. So they're really good at picking up certain patterns, and they're much better at picking up, like changes in, dysmorphic features, some of these other things, which a lot of times if something's going to cause a problem, like an exposure, like alcohol, right? We see certain features with fetal alcohol spectrum disorder that are on there. So what has happened, and speaking of alcohol, it really was an astute clinician who noticed, hey, I'm seeing these patterns. I can't find necessarily a genetic etiology for this or something else. What else is going on? Okay, it looks like everybody here was exposed to alcohol during pregnancy. And we're seeing that right now with fentanyl and Smith-Lemli opiates. There are several case reports of children born with, you know, classic features of Smith-Lemli opiates. They get a genetics workup and they do not have Smith-Lemli opiates. And now we're learning how these two pathways and kind of cholesterol biosynthesis may be affected by fentanyl exposure. But we're still very early in figuring out what all that is. But we've noticed the pattern. And that was an astute clinician who was like, okay, hold up. What am I if it's not genetic, what else could it be? So that's one of the things is that we just overlap in handling or caring for individuals who have birth defects, but also or neurodevelopmental changes. And then the other thing is that we get trained to count on counseling uncertainty, right? Like we do that.
Right.
There's really not much that's different in the skills that I utilize when I do teratogen counseling versus when I do regular prenatal counseling, because a lot of it is really just managing uncertainty, but also communicating risks in a way that somebody can make informed choices and informed decisions and not be scared necessarily or alarmed, right? Because I think the reality is that not a lot of people have those skills or have the time to practice them like we do. And I think it kind of falls really well within our purview to be able to do it and ultimately use our communication skills and use our understanding of data, but also communicate uncertainty to be able to provide that service.
And it was interesting you mentioned about the crossover in seeing kiddos that may have some sort of developmental delay or maybe were born with a birth defect and then trying to tease out, is it a genetic cause? Is it a teratogenic cause? Is it something else altogether? What do you do prenatally? So somebody comes to you, says, I'm concerned about an exposure. How do I know if something actually happened? Like, are there any tests to figure this out before the baby's born?
We don't have a lot of good, information. I think the best tests that we do have are imaging tests to give reassurance, right? We can't, as far as sort of functional and neurodevelopmental things, those things are really hard to assess until kiddos are at a time where you can assess their development, which, by that time they've had 5 years of exposures in their environment outside of the womb, right?
Mhm.
But we can do imaging, and generally what we would do is anatomy scans, which typically happen around 18 to 22 weeks of pregnancy. And hopefully if somebody has had an exposure, especially an exposure that's known to potentially increase risk, the goal would be to have that done at a center where they have better modalities in imaging, ideally with a maternal fetal medicine specialist if possible. And we can assess kind of how the organs have developed. And then on top of that, we can do some additional imaging. So if we're worried about potentially heart being affected, then we can do a fetal screening echo to take a look. And then we check growth and fluid checks kind of throughout the third trimester of pregnancy. So we can do a lot to hopefully give reassurance as far as kind of the structural things and some of the functional things like the kidneys and the growth. But there's not a perfect test. We don't have any great blood screens, anything like that. There is a hope down the line which would change some of our understanding about teratogens is being able to use some of these like biomarkers and amounts of medications in blood and all of these things to
Mhm.
kind of get us a sense. But I don't think we're anywhere near that to actually be useful in patient counseling currently.
And one of the things I think that comes up a lot in counseling teratogens or talking to a pregnant person is that there can be a lot of self-blame or saying, "Why did I take this?" or "I didn't know I was pregnant," or things like that. So how do you work with someone who's blaming themselves for an exposure or feels like they're being blamed by others?
I think that's probably the most difficult thing is that we tend to see, especially patients who are pregnant, they don't give themselves a lot of grace. Now, I will say that as a mom of four kiddos, I don't give myself a lot of grace, right? Like I think that is a little bit of a just a general, I think, society pressure that we all have. I think what I try to bring it to as best as I can to patients is going back to the reason behind a lot of things. Most people are not doing something with an intention to harm, and most people are trying to take care of themselves the best they can. And I sometimes, I used to have a supervisor who would always say, when you're on a plane, if you fly, they always tell you put your mask on first before you put it on your child, because realistically, you cannot have a healthy baby without a healthy mom. And we're seeing a lot of these things pan out in our general population where maternal health is definitely dropping and maternal death rates are increasing. All of these things that are ultimately extremely important for a child's development, right? You need to have a person there. So I think I always bring it back to, like, why are we doing this? Why did you do this in the first place? And kind of putting it in perspective that it's not all risk, that there is
Right.
benefit, and thinking about what are the benefits and trying to reframe it as best as we can. And then thinking a little bit about, what their anxiety level and what their state of mind is. There are some people who are always going to be worried, right? No matter what. And I think that's understandable because, again, some of us do have a lot of anxiety about a lot of things that we can't control. That's the underlying, diagnosis of anxiety, right? But
Mhm.
but I think a lot of times what happens is just being able to put it in perspective and let them know that there are people who are supporting them in that. Because I think what I see a lot is because a lot of healthcare providers are not comfortable with pregnancy, they tend to, maybe inadvertently, oftentimes inadvertently, put blame, even by sometimes saying, "Oh, I have to refer you out," as opposed to being like, "Okay, here's what's available on this data. I'm not really too concerned," or "Let's talk about it," or "What are you more worried about?" Sometimes people get more worried because somebody brings it up, even though they may not have been worried about it. So again, I try my best to put that in perspective as best as I can and talk about, like, what are we doing this for? And then putting some of these other things in perspective too. I always, moms will come in and we have a lot of patients with high blood pressure and they get put on medications. We don't think about it twice. We put them on medications, but some of the medications we put them on, we actually have less data on because they're not usually used when you're in reproductive age. They're usually used, in your 50s and 60s when people are not having kids. But we don't think about that twice because the benefit is very clear, right? You can see numbers on a cuff. I try to normalize that just because I can't see somebody's, flare, or I may not be able to see their mental health struggle, or I can't feel their pain, that does not mean that it's not there, and that we're doing the same thing in the biological process. The body was telling us that there's something going on and that we need to take care of it.
What are some resources that you would tell pregnant patients to look into, or if they have specific questions about exposures, where can they go to find out more?
Yeah. So I think obviously one of them is Mother to Baby. It is a free resource for both patients and providers, including genetic counselors. Because again, I think not that healthcare providers are not able to do all of this, but we don't have time, right? We have a lot of hats that we wear, and Mother to Baby is a resource where there are individuals. So again, we are extra trained and get additional continual education on just being able to look through all of these nuances and review this data and kind of come up with a risk assessment. But Mother to Baby has a website that's a great website, has a lot of fact sheets. We have hundreds of fact sheets that give us information in kind of patient friendly language about various exposures. But it's also free to call, email, text, or chat, and you are always going to get an information specialist. And even if it's something like really, really odd and weird, and we have resources to a national and international web of experts who, not everything is published, but they may have information on usage of things. So I welcome everybody to utilize Mother to Baby, but also, obviously literature is always a good place to go if you ever need to look things up. And then there are books and various databases that are trustworthy and have information on there. I think the limitation to those is oftentimes they do have to be paid for, right? And we have access to all of that, but it's a free resource.
Okay. And we'll definitely put a link to Mother to Baby as well as some other resources in the show notes. And Nevena, again, thank you so much. I know we've covered a lot. I do feel like there's more we could talk about, but I think this is a good start to hopefully have people learn a little bit more about teratogens, what they are, how challenging it can be to assess how harmful something could be, if at all, and also where to go to get more information. So thank you so much for being on the show today.
Yeah, of course. Thank you so much for having me.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.